Welcome to Top Med Talk. The Society of Cardiovascular Anesthesiologists annual general meeting is coming soon. Check out scahq.org now. More details at the end of the podcast.
Top Med Talk.
Hi, everyone. It's great to be here today, and thanks very much to the EBPOM organizers for allowing me to be here. My name is Michael Grant. I'm an associate professor in the Department of Anesthesia and Critical Care at Johns Hopkins Medical Institutions, and I've been asked here today to talk a little bit about the cardiac enhanced recovery movement and really the updates that have happened over the course of the last couple of years. Over the next maybe 20 minutes or so, I really want to talk about four major areas when I think about an update to enhanced recovery. So certainly in the area of investigation, I think it's important for everybody to understand where kind of the various research trends have gone in that time frame. But I think it's been really exciting because over the course of those last couple of years, cardiac ERAS has really matured a lot and started turning its focus towards implementation science, integration of some of these various aspects into the everyday workflow. And then we've done a lot of work, as you can imagine, in the area of dissemination, getting the word out and letting the world be a part of this movement. And so I'll spend a lot of time talking about each one of these individual components. So the first one's in the area of investigation. Obviously the research trends are really important. As people who've been following the enhanced recovery movement know, this essentially did not exist up until about the year 2000, when we started seeing more or less an explosion in interest in the enhanced recovery concept. If you were to go into PubMed and just simply put in the phrase ERAS, you'd see, obviously over the course of the last couple of years in particular, just an absolute explosion in the literature around this topic. Hundreds and hundreds of articles are published on this annually. Well, it turns out in cardiac ERAS, it's very much the same. On the right-hand side, this was something that I just recently looked at. We've seen, again, almost no awareness of this concept in the early 2000s, exploded more recently. And in fact, last year, we're starting to see enough articles that we're actually starting to get our hands around some of the literature in this area. And coincident with that has been a maturity in the way we think about enhanced recovery, especially as it pertains to cardiac surgery. And you may recall, those of you who have followed cardiac enhanced recovery, that kind of the initial forays into this topic really began with just kind of some of those feasibility studies. How can we practically apply some of these concepts to just basic procedures? And those were informative because it really told us, of course, that these could be applied to a really complex caseload of patients. And perhaps more recently, we've seen that those have become a lot more mature. We have a randomized clinical trial published a couple of years ago in a European journal. And then more recently, we have full examples of programs of enhanced recovery. The first domestic one was published in 2019 by a group out of Wake Medical Institutes. And what's really exciting is that we're starting to see full mature programs that exist and really become benchmarks for how we can think about this movement across the United States and then obviously internationally, which is why we're here today. I think equally impressive is that not only are we starting to see examples of mature, fully comprised, all phase of care outlines, but we're seeing additional examples. So just this past month in the Annals of Thoracic Surgery, we saw an example from community practice, largely just community-based as opposed to our full academic models. We've seen certainly more recently that there's been adoption of these various programs in pediatrics. The first congenital cardiac example has been published, and then in LVADs, which is kind of the new frontier, we're thinking about how we can think about mechanical support devices. And in fact, we are applying enhanced recovery principles not just to some of those more pathway-driven cases, but perhaps to the ones that are maybe a little bit more esoteric. We're looking forward potentially to seeing examples of this even in transplant surgery. Beyond just the kind of full scale, not to say otherwise maybe run-of-the-mill enhanced recovery, we have to be also aware of the fact that the literature is very specific to cardiac in many ways. In the first iterations of enhanced recovery, we have largely applied a number of the particular interventions that maybe were specific to colorectal surgery or some of the maybe broader surgical populations, and we've brought them over in surrogacy to cardiac. Well, what's been really exciting about the literature over the last couple of years is that there's been more focus provided specifically to what makes cardiac surgery unique. And some of those examples are outlined here, and I'll give you examples of what that looks like in the literature as well. We'll dive into each one of these individual topics and kind of give you a little bit of a sense of where we've come over the course of that time. One of the exciting areas is that not just are we aware of the harms of opioids in some of the general cases, colorectal surgery, gynecology, some of the more kind of traditional bread and butter procedures, but now we're more aware of the role of opioids and perhaps how harmful they might be in cardiac surgery as well. Now, this includes some of the individual basis for opioid harms, things, of course, like ileus. Believe it or not, it exists in cardiac surgery as well, but even opioid-related adverse events. There's actually a really interesting study published a couple of years ago in Seminars that suggests that perhaps this is one of maybe the most underappreciated areas of cardiac surgery, where we may document as little as 1% of patients with opioid-related adverse events, but in fact, maybe as much as 30% experience one. Even more damningly, we're seeing that opioids last with patients even after surgery is completed. One example of that is in something called new persistent opioid use, where patients may otherwise be naive to opioids coming into surgery, but stay with some chronic opioid requirement as much as 90 or 120 days afterwards. And as you can see depicted on the right-hand side here, CABG, some other valve procedures may have as much as 12, maybe even 15%, depending upon the study that you're reviewing, 15% incidence of persistent opioid use. And quite interestingly, there's an inflection point. Patients who are prescribed a certain dose of opioids upon discharge have a much higher likelihood of requiring those opioids long-term. And that's something that I think we've all become quite aware of, and then therefore we've started to devise strategies on how to mitigate that issue. But there's a challenge in this area. Opioid reduction, although a core measure of most enhanced recovery programs, tends to not be particularly well studied in cardiac surgery, in large part because we didn't realize it was an issue. As many know, in non-cardiac surgery, there's a host of different outlines, randomized controlled trials, meta-analyses that have specifically looked at individual non-opioid medications and techniques to allow us to mitigate some of the opioid requirements. Well, it turns out that if you compare that directly to cardiac surgery, the bulk of the data just doesn't exist. Now, it's perhaps reasonable to apply a couple of these individual agents and the lessons we've learned from, say, colorectal surgery to cardiac surgery, but the populations are inherently different. And some of the side effects associated with these agents are particularly problematic in the setting of cardiac surgery. A great example of that, of course, would be NSAIDs. Although they're a commonplace, run-of-the-mill, we should use these agents in all comers kind of medication for non-cardiac surgery. As we know, in cardiac surgery, as many as 30% of patients suffer from some form of acute kidney injury. And in fact, there's an FDA black box warning against their use in coronary artery disease. And so that really creates a conundrum for us as we move forward. Now, suffice it to say, there are alternatives, and alternatives exist in a number of forms. One of the things that we are particularly excited about, of course, is that regional, which is, again, another backbone component of enhanced recovery across most surgical service lines, exists for cardiac surgery now as well. We're seeing better and better examples of this being applied. We now have early kind of exploratory examples of this, single-shot techniques and catheter-based techniques. There are, of course, strategies for regional analgesia that exist for median sternotomy, as well as thoracotomy for minimally invasive procedures. And so the reality is that we're going to see over the course of the next coming years a genuine excitement around the use of regional analgesia as it applies to cardiac surgery. And I think this will really tip the scales and allow us to start to look towards true opioid-sparing technique. One example of kind of a comprehensive outline of opioid-sparing anesthetics came from our own group at Johns Hopkins. We took a look at a number of different interventions. They're listed on the right-hand side, but they include kind of the strategic use of complementary anesthetics in ketamine, dexmedetomidine, the scheduled use of acetaminophen and gabapentin, and then, of course, regional analgesia. And what we found was that patients initially experienced quite a large dose of opioids in the operating room. This is very common for cardiac surgery, as many understand. And what we found is as over the program's duration, we not only saw a significant increase in the application of these non-opioid multimodal techniques, but we saw a concomitant reduction in overall mean intraoperative opioid use. And in fact, at the end of the completion of this particular study, we found we were actually using less opioids for a cardiac surgical case than we did for our own outpatient cystoscopy procedures, which is incredibly telling, but also really exciting. Another area that I think is particularly interesting and one that's compelling for those who are doing cardiac surgery specifically is the area of enhanced recovery as it pertains to early extubation. As many know, there was a push in the early 2000s for something called fast-track cardiac surgery or fast-track cardiac anesthesia. And one of the real hallmarks of that was this idea that patients could be extubated much earlier after the surgery. And at the time, the mark was somewhere around 12 to 24 hours. Well, more recently, the STS, the Society of Thoracic Surgeons, has really been pushing for quality measures to exist where we extubate patients within 6 hours instead. And our own protocol, again, at Johns Hopkins, not only explored the opportunity of using a number of the techniques and therapies that I just described for opioid reduction, but also apply them to early extubation rates. And what we found, of course, was that there was a significant reduction in early extubation up to 6 hours after surgery. But even more interestingly, and this is an area somewhat unexplored really in the area of cardiac surgery, is that we are now enjoying an opportunity to extubate patients in the operating room. Obviously, coupled with the right protoplasm, so to speak, and the right protocolization, we've now been able to extubate patients upwards of 30 to 40% of the time in the operating room proper. And it turns out there are some other examples in the literature of people who are doing this on a routine basis. So that's a really exciting area of inquiry and an exciting area of recovery for these patients. I think another area, of course, that we should be specific to cardiac surgery is in the area of organ perfusion. One thing that happens in the operating room for cardiac surgery, which is a unique therapy or a unique monitoring system, is the use of transesophageal echo. And one of the things that's come up more recently is a discussion around what are the merits of using or not using this particular monitoring technique in all comers, all patients undergoing cardiac surgery. What we found in a recent use of the STS database across 1.3 million patients undergoing coronary artery bypass surgery was that transesophageal actually improves outcomes to the point that it not only can, in many ways, dictate the kind of procedure you're doing in the operating room, but may actually reduce mortality rates after coronary artery disease, which is something that had not been previously shown. We've understood the value of echo for valve disease, but now we're increasingly understanding how it can be valuable to us for coronary artery disease and CABG in particular, and how it can actually guide therapies that are happening in the operating room and potentially sometime thereafter, depending upon the disease process that we're talking about. But there's also another kind of elephant in the room, so to speak, maybe black box is maybe another way to think about it, and that is this cardiopulmonary bypass machine. More often than not, patients still in today's cardiac procedures require cardiopulmonary bypass, and that's a big phase of the procedure. In some cases, it lasts several hours in the operating room, and there are increasing interest in us devising strategies to have a more goal-oriented approach to how we manage cardiopulmonary bypass in that phase of care. And there have been increasing examples of us thinking about doing just that. The best examples that we've seen in the last couple of years are that some have specifically looked at the targeted use of oxygen delivery, as well as a protocolized approach to managing hypotension and ultrafiltration. And the idea ultimately being, how can we mitigate some of the potential side effects of cardiopulmonary bypass? And the two that come to mind most readily are, of course, postoperative cognitive dysfunction and AKI. What we found is that through the targeted use of goal-directed perfusion, we've seen a significant reduction in overall AKI rates afterwards. There are several examples of this. And then a more recent example has looked at the targeted use of perfusion as it pertains to maintaining a mean arterial pressure more consistent with a patient's baseline, or perhaps within their own cerebral autoregulation curve. And what that allows for us to do using this more individualized approach is potentially stave off issues with postoperative delirium. This was information that was provided a colleague of mine from Johns Hopkins. It's really exciting material that lets us know that the way that we manage that perfusion machine and those several hours that we can potentially promote organ perfusion can have really long-lasting impacts. Another area that is specific to cardiac surgery is, as I mentioned before, the fact that our AKI rates are significantly higher than most other surgery subtypes. An example out of Dr. Engelman's group at Bay State is that they have really strategically utilized early urinary biomarkers, things that are a little more specific than perhaps just a basic creatinine would be, and devise goal-directed strategies around how to manage patients' overall hemodynamic profile. They've tied with that this notion of potentially achieving higher mean arterial pressures. They also look very specifically at transfusion rates. And the long story short is that they've devised a strategy using these various therapies to reduce and almost eliminate stage 2 and 3 AKI from their surgical populations. Again, really exciting information, something that can be incorporated specifically into the cardiac surgical population. I'd be remiss if I went through this entire thing and didn't explain how important blood management is. As many know, the transfusion rates within the realm of cardiac surgery are significantly higher than other surgical subtypes as well. And more recently, there's been an appreciation for really a three-pronged approach to blood conservation. There's an increasing interest in preoperative optimization through the use of strategic preoperative planning with iron, nutrition optimization, and potentially even the use of erythropoietin. Intraoperative conservation, which are kind of, again, hallmarks of enhanced recovery, specifically as it pertains to cardiac surgery. And then also, of course, being really specific about your transfusion algorithms and strategically using blood products in a reasonable fashion. All of this is shown to significantly reduce the incidence of transfusion in cardiac surgery. But maybe just as exciting, more recently, we've seen that there are examples of what we call ultra rapid preoperative optimization, where you can actually get to the patient just the night prior to surgery and apply a couple of different therapies. And as at least one Lancet article in 2019 suggests, that can be associated with not only an increased overall rate of hemoglobin within the first couple of days after surgery, but can significantly reduce transfusion rates. And that's really compelling because, as many know, particularly in the domestic United States, patients have to undergo surgery sometimes quite urgently and maybe don't have the preemptive time frame to do some of the planning that we hope for. So this gives us an indication that perhaps some of these therapies can be done in the acute setting, which is, again, really exciting. And then lastly, but perhaps not least, there are a couple of things that are specific to enhanced recovery for cardiac surgery as it pertains to foreign material. Obviously, one of the things we really think about as a backbone for enhanced recovery is the removal of unnecessary tubes and drains. It's no different in cardiac surgery, but there are a couple of realities. One of the other realities here is that we think an awful lot about how we are closing the sternum in cardiac surgery, and how does that contribute both to sternal breakdown, how does it contribute potentially to surgical site infection rates, and then, of course, overall pain rates. And so one of the areas of particular inquiry is to potentially think about doing rigid sternal plating as opposed to using our traditional approach, which is wire cerclage. Similarly, we're looking at things like active chest tube clearance and the removal of foreign blood material from around the heart, which can be a nidus for AFib, but obviously can also have more catastrophic issues such as tamponade or other retained blood side effects. And so these are areas that are particular to cardiac surgery. They're topics of ongoing debate, to be honest. And what's really exciting about the literature is that, again, we're seeing more and more discussion around these themes. And I think it's important because this gives us yet even more data to derive best practice for our patients. But the reality is it's not all about just the investigation or the specific inquiry into the individual interventions that surround cardiac surgery. There's also been a big movement around trying to understand how to actually apply these principles in the real world. And so another phase of kind of exciting advancement in the area of cardiac ERAS is really an implementation. So how do we actually do in the cardiac ERAS concept? And one of the areas that has been highlighted in the literature more recently, and this is from a number of different groups, is the use of continuous cycles of improvement. And there's a couple of depiction here. One on the left-hand side is from that Wake Medical group, where they specifically look at the knowledge to action framework. And this is really an education framework. The idea being, of course, that you devise the information that's necessary, get it to your frontlines providers as well as your patients, work that around to allow that to really inform your decisioning within the actual program itself. You feed back upon itself, you derive some of the local knowledge from those providers, and then you feed it yet again back through the cycle. And so this helps to improve upon the care pathway as you go along and improves the education for the entire team as well as the patients themselves. Similarly, our own group has taken a look at this and built an outline of sorts on how to continuously both develop programs, implement programs, but then also seek feedback and have future growth. And that's depicted here graphically. And what's, again, exciting about the literature is that we're seeing more and more examples of people who have been focused on how implementation is just as critical as understanding what the right thing to do actually is. At our own institution, we've opted for something called the Comprehensive Unit-Based Safety Program. And what this does is it blends a combination of the technical components, ergo the individual interventions that are evidence-based and lend themselves towards standardization, but we blend those with the more adaptive components. That is the kind of cultural manifestation of your local unit or group. And what this allows you to do is really understand that the engagement of those providers and then the accountability afforded by engaging your administrative liaisons is just as important as the interventions themselves. And the Comprehensive Unit-Based Safety Program provides a grassroots opportunity for both your local nursing and provider structure to own the program and to iterate upon that program and make it better as you go forward. Again, allowing for some of those practical aspects to come through. At END, it's reasserted over and over again that each of these movements are very patient-centered. As you can see from this depiction from the National Improving Surgical Care and Recovery contract in the United States, that the patient, again, remains the center point and the focus of all of this. And as you think about your coordination and improvement and senior leadership teams, all of those fit within the context of what is best for the patient. And that's true of cardiac enhanced recovery as well. And then lastly, it's important to acknowledge that COVID has been a real impact in the entire enhanced recovery movement. It's no different for cardiac enhanced recovery. There's a great article from JCVA just this past year that showed that the same resources that we might be applying for cardiac surgery, ICU beds, ventilators, some of our vasoactive medications, strategic sedation, even ECMO, are not just necessary for cardiac surgery, but they're equally necessary for COVID. And that creates this real challenge where you're trying to balance the needs of one over the other. And similarly, as you are trying to install an enhanced recovery program, you have to be mindful of the fact that those are going to have push and pull against one another. And so acknowledging that this is a real challenge for local infrastructures, I think is important. And this article really outlines that quite nicely. So as we go forward, this is increasingly looking like it's going to be a part of our everyday experience. And so these lessons continue to be learned as we press on. I think another area of particular excitement is in the area of integration. It's really important not only as you're thinking about implementation and looking at the right interventions to make this easy for your bedside providers. And that's really done through integration primarily. And one example of this, of course, is that anybody who participates in the Society for Thoracic Surgeons national database, again, this is domestic United States, they're asked to pull a lot of data, and those data all go into a large repository that informs not only quality metrics, but helps you understand where you lie as a center of excellence for cardiac surgery. Well, I think very similarly, these essential data elements need to be collected for enhanced recovery programs. And an example of this that was recently published was that there was a modified Delphi panel of experts that came together and decided that there were, in fact, individual elements that needed to be collected for the sake of enhanced recovery. They're included here and depicted, but I encourage you to go take a look at this particular outline because it's a really nice way to think about how your program compares for these kind of core elements for enhanced recovery. And looking forward, we anticipate that a number of these will be adopted into the SDS database or similar databases to allow us to designate centers of excellence and to think about your program as a 3-star enhanced recovery program. We're seeing more and more examples of the importance of patient-reported outcomes. This is not specific to cardiac surgery, but they are included as well. This includes, of course, individualized patient follow-up. That is simply phone calls to all of your patients, but it's become really much more complex than that. We now have opportunities to provide phone and web-based applications. These provide you an opportunity to question the patient about specific endpoints that are of interest to them. This includes things like patient satisfaction scores and allowing them to give us their interpretation of their experience. Just as excitingly, we're seeing more and more examples of the use of actigraphy and remote monitoring and surveillance, allowing us to have a sense of how standard recovery looks like after cardiac surgery and compare that to allow us to identify outliers and monitor in a very special way that, when done on a remote basis, allows patients to leave the hospital but yet still feel as though their recovery is being conscientiously followed. There's an area I think that of particular interest, and that is in this notion of situational awareness. That is, how do your providers understand that things are progressing? And one of those examples is in the area of opioids. Obviously, in order for us to think about opioid management after surgery, we have to be very conscientious of how much opioid a patient requires. Now, traditionally, it looks a lot like it does here on the left. You have to go to the chart. You have to look at individual agents that patients are receiving. You have to do a bunch of conversion, and based upon all your calculations, you ultimately come up with what you think is an overall profile of opioid use. Well, it turns out there's now web-based applications that can be placed into your electronic medical record and allow your providers to see in real time what the opioid requirements are. And as you can imagine, this pathway, this framework can be applied to a number of different interventions that allow for improved situational awareness, not only around opioid management for surgery, but a host of other agents, whether that be vasopressors or nutrition or ambulation. Each one of these can be followed in a very granular fashion, but done without adding extra requirements to the workflow of the bedside provider. And ultimately, this will all feed back into the strategic use of real-time dashboards. This is an example from our own institution we published on quite recently, and this looks very specifically at quality dashboards pertinent to a number of different outlines. And this can get so granular, in fact, that you can have examples of even individual medication usages over time. Depicted here are some run charts that specifically look at our overall use of various agents. These are medications depicted here, but as you can see scrolling across the top, that we look at a whole host of different outcomes. We can look at these in a very granular way and use them to strategize and prioritize our own quality initiatives. And this feeds back into our enhanced recovery program and matures that program over the course of many, many years. And while all of that is really, really exciting and important to be done on a local level, I think perhaps the best area that we can provide value going forward is in the area of dissemination. How do we share enhanced recovery with the world? And there's been a lot of work in this area. One of the best examples is the recent guidelines for perioperative care and cardiac surgery. This has been viewed more than 200,000 times and has more than 45,000 downloads. Its citation rate goes up every single year, but what's most important about this is this has become really the kind of backbone for how we care for these patients. And I'm excited to report that we're looking to update these guidelines in the next 12 to 18 months, because as I've outlined throughout the course of this talk, the literature just pours in every year, and it's important to allow for these guidelines to exist as much in a real-time sense as possible to keep people abreast of the best way to care for their patients. Similarly, we've forged international collaborations for cardiac ERAS. Depicted here are just some of those examples. This is not an exhaustive list, but gives you a sense of how this is no longer just a North American phenomenon or perhaps a European phenomenon, but that we've expanded this footprint across the entire world. And these partnerships continue to spring up as we go forward. Again, very exciting to see such an explosion in interest in this topic, culminating perhaps in more recently, very specifically, we started the Cardiac Society Experience, which is an annual virtual conference, the most recent of which was this past March, where we had over 1,500 participants across 40 countries. And this has really forged partnerships with all of the major US-based societies collaborations with Europe as well, and the list goes on. And what I'm excited to report is that we are seeing more and more people get excited about this movement. And I see a bright future ahead, of course, for enhanced recovery. And I think the lessons that have been learned from some of the thought leaders in this area are now being applied in the community and more rural settings. And those experiences can be fed back, of course, and disseminated even more broadly. And so it's an exciting opportunity to move forward with enhanced recovery. And so those are some of the major features of enhanced recovery. This is the update over the last couple of years. I really appreciate the organizers of EBPOM allowing me a few minutes to discuss this today. And thanks again.
Top Med Talk.
The Society of Cardiovascular Anesthesiologists' 44th annual meeting is coming soon, and Top Med Talk will be there. If you want to pop along and see us, it's on May the 14th to the 17th in Palm Springs, California. Check out scahq.org now for special offers and more details. Also, if you're not sure if you can make it in person, why not explore the virtual track? Innovation during COVID-19 now means more than 60% of this year's sessions will also be fully available for you online. Check out scahq.org. That's scahq.org.